Welcome to What's Next, Previews, Predictions, and Prognostications. I'm your host, Rhett Power. Joining me is my host, John Baldoni. John, how you doing?
Great.
Whether you own your own company or work for one, you need information on what we can expect in the wake of COVID-19 and all the social unrest that we're facing here as a country. We interview on this show thought leaders and doers from the world of business, science, medicine, economics, media, psychology, who will help us shape the new normal. So let's get started with that. John is going to welcome our guest today. John, I'm going to turn it over to you.
Thank you, Rhett. We have a very special program today, and one that's near to my heart. Here we are in my own hometown of Ann Arbor, Michigan, where we have two renowned physicians, both from the University of Michigan, where my father was a graduate of the 1955 class of medical school. So it's near and dear to my heart. And my wife is also works in an institute at the University of Michigan Medical School. So it's a personal pride for me to introduce Dr. Preethi Malani, who is the Chief Health Officer and Professor of Infectious Diseases at the University of Michigan. She advises the university president on matters of health and well-being of the university. And with her background in infectious diseases, her expertise is of particular note. And she also does some advising on college athletic programs. Our other guest is Dr. John Ayanian, who is a physician and runs the Institute for Healthcare Policy Innovation at the University of Michigan. He has a long history in public health and is also a practicing clinician, and will give us an up-close and personal look at the health effects of COVID. So first question, Dr. Malani, what's the efficacy of treatments and the state of vaccine for our COVID-19?
So thanks, John, for that very easy question. So treatments, there's been some good progress. And I would say there have been a few big trials that are worth noting. One that got a lot of attention was on the drug remdesivir, which showed some benefit. And again, the use of that drug is going to be in patients with very severe illness. So not people walking around who are ill at home, but those who are mostly in the hospital and even the ICU. And again, that benefit is sort of small. The other therapeutic intervention that's gotten some attention is with convalescent plasma. So this is removing the plasma portion of the blood from donors who've had infection and then getting that into a form that can be given to patients who are ill. And that too is looking like it has some benefit. So those are two things on the treatment front. There are lots of other things being looked at, and also just the way we take care of patients is being looked at. But it's going to be a vaccine, as you asked about, that gets us out of this pandemic and into the next phase. And there's also been good movement there. And of course, we don't have final results, but things are moving along, and some of the vaccines are entering sort of the final stages. The Moderna one has gotten a lot of attention, and that's going to go to the next phase in July, is what we're told. So hopefully one of the vaccines that's being looked at and alongside with being studied is these are being made. So in the event that they are in fact safe and produce the right type of immune response and prevent infection, then they can be administered. But it's the timeline is there's a wide range of where it could be.
This is sort of for both of you, both of our guest doctors to sort of weigh in on. But, a lot of people are struggling now with how to return to the office and how to reopen our offices. And is there any advice that you guys can give to business owners and teams that are sort of trying to put these policies in place? And then once we go back, how long do you think that we're going to be in this, or should be in this, social distancing kind of phase?
Rhett, that's an important question and one that we're all grappling with. I know our own university and health system has issued guidelines that are consistent with the policies of our governor and State Department of Health and Human Services in Michigan. And those in turn are consistent with what the Centers for Disease Control and Prevention, or CDC, at the federal level has been encouraging. To the extent possible, people who can still work remotely from home are encouraged to continue doing so, especially in areas that have significant numbers of individuals with COVID-19 infections. There are certain types of work, for example, in a university setting, certain types of laboratory research, some of which is focusing on trying to develop new tests and treatments for coronavirus. That work has to be done in person. But within our setting at the university, and I think many other employers are following similar guidelines, we're bringing in reduced numbers of staff to work so that they can be spaced out. We're extending the workday from the normal 8 or 9 hours to 12 to 16 hours, and bringing people in multiple shifts.
Okay.
And to the extent possible, certainly some of the worst parts of the outbreak have been in places like meatpacking plants or prisons, where people are crowded almost by design, just by the nature of the work and how those organizations function. But for most businesses, particularly ones where people can work remotely, I think it's still advisable to continue that remote work. And we're learning a lot in the process through events like this discussion today about how we can communicate effectively with each other. When people do need to be out and about, and especially in enclosed indoor spaces, wearing masks or face coverings are an important part of slowing the spread of the infection. There's starting to be some growing evidence that they make a difference, as well as the policies that governors have issued for individuals to shelter at home or stay at home during the peak periods of the pandemic, that those appear to be making a difference in what we call flattening the curve. And really, in the early parts of this pandemic, we were trying to protect our hospitals and intensive care units so that they were available and able to take care of the people who needed them. Here in Michigan, we had a number of hospitals that filled to capacity and were overflowing, and we had to move patients between hospitals. And similar things happened in New York City and some other parts of the country. And so that's, we want hospitals and intensive care units to be available for the people who need them. And that's a big part of why we're pushing these public health measures that affect when we can return to work.
How long, John, how long is it going to last? I know that's a really unfair question, but what is your sense? I'm sorry to interrupt you, John Baldoni, but what is your sense of the timing on how long this is going to be? Because I know that's a burning question I get from CEOs all the time, is how long do we have to sort of maintain this?
Well, and I think I'd be interested in Preeti's thoughts as well, but my sense is until we have a vaccine, not just widely available, but actually administered to large numbers of the population, we will continue to deal with new coronavirus infections. There are some places in the world like New Zealand that are very self-contained, where countries have been able to, I think by reducing visitors from outside and travel within the country, they've been able to bring the level of new infections down to a very manageable number, close to zero in some cases. But a country like the United States, which even with some of the travel restrictions that we have in place, people are still coming and going, both from other countries and within the United States. I think there's just ample opportunity for the infection to spread. And as the economy opens up and we start holding rallies and other large gatherings, that may only increase the risk of spreading infection.
Thank you.
You want to say something on that, Dr. Malani, about how long it's going to last and an impact on, because you were in a university and you had advised the president. So what's the thinking going on at the university level for bringing students back?
Yeah, so this is one of many difficult issues to try to sort out with COVID. In a sense, with the university, you're trying to design a university that is the opposite of what it's designed for, which is togetherness. You're trying to design a system where you could socially distance, and everything that you would normally want to do together and create community, you can't do. And of course, universities they have a lot of people and often in shared living quarters, whether it's a fraternity house or a residence hall. And so you worry about spread there. Now, on the flip side, you also need to continue the work of the university. And as Dr. Ayanian mentioned, our research is one element that we have actually increased, and we've been in this ramp up phase. Ramping down was pretty easy. You just basically shut the door and turned off the light. But getting back has been really complicated. It's been a really intensive process of planning. And as we're thinking about the fall, and there isn't not a final decision, although one is expected soon, and optimism has been expressed, but our president's going to make a final decision in the coming days. It is really important that we do try and get students back, because remote learning is different. And although it has, it's good enough in a lot of places, it creates a lot of barriers to learning for people who are particularly vulnerable, and it's just not the same. So my sense is that and a number of universities have said we're coming back. None of them are going to look quite the way they did last fall. And there'll be a number of things that will sort of not be essential, but the essential piece of learning needs to continue.
Hey, how is one of the concerns, and I'm just fascinated by the conversation at the university level, and I imagine it's going on at all universities, but is there a concern because the students aren't in the higher risk category, but a lot of the professors are, and a lot of the teachers are? Is that part of the conversation on how to take care of the staff?
Absolutely, Rhett. That is a very critical part of it. And, although students themselves tend to be in what we think of as low risk categories, I don't think we fully understand what their risk is. I know my son, who's a college student, one of his friends recently was diagnosed with a cardiac issue after having presumed COVID. So, if enough of them get sick, there will be some that have complications. And we're hearing about these younger kids with this Kawasaki-like syndrome that, again, we don't understand the denominator, so it's hard to put a risk on it. We sort of know what some risks are, but this is hard because we don't have a good sense of risk. That conversation around faculty and staff is front and center. And one of the big discussions is, can you design a system so that it is safe to be back in the classroom? And we touched on that in an earlier question in terms of just getting back and re-engaging. And there are a lot of people who've been home, and they've been following in our state, our governor's orders about stay home, stay safe. And the idea of going back out and venturing out can create anxieties for people. Right. And
I'm glad, Dr. Malani, you mentioned the unknown factors of COVID, because as things have opened up, we're kind of getting the feeling there, at least mentally, we're past it, and we're actually not. But also, this is not a bad flu. It has some very serious implications. So, John, what is the public health aspect of this? How is this impacting how we deliver healthcare?
Well, early on, we essentially, to create the hospital capacity that we needed, not knowing how many people would require hospitalization, intensive care. So at least in Michigan, going back from about mid-March forward until, I would say the very recent weeks, we had cut way back on all elective services, elective surgical procedures, even some more urgent surgical procedures that were not life-saving, that could be delayed by weeks or a few months. Most of that was postponed. In the ambulatory or outpatient setting, we canceled all the appointments except the most urgent ones and discouraged people from coming in because we wanted to make our waiting rooms and offices as safe as possible so people weren't exposed to the virus coming in to see their doctors and nurses. So now we're in the recovery phase, at least here in southeastern Michigan. We have, I've been back in my internal medicine clinic the past 2 weeks. We've brought both our doctors and patients back in smaller numbers so that we can space patients out in the waiting rooms and have more time to clean our exam rooms where doctors and patients meet. And so, we're kind of gradually, whereas we shut down very quickly back in March, most of our non-emergency care, we're now slowly reopening those services, and our hospitals and operating rooms are starting to fill up again with some of those services and treatments that were postponed for 2 to 3 months when the pandemic was at its peak. But we've got to do this all very carefully. As I mentioned, in our hospitals and medical offices, we're all wearing masks, patients and staff. We're all maintaining that 6 feet or more of physical distancing as much as possible, except for the most essential parts of a physical exam, for example. And we're also trying to ensure that people with major chronic illnesses like diabetes and high blood pressure and heart disease, that they're not suffering for lack of care, because I think one of the things we're going to be learning is sort of what the implications were of people, postponing medical care for a several month period, and making sure that they get back in for the treatments and the tests that they need, because there could be spillover effects, not just from the ill effects of the coronavirus, but from people avoiding medical care during the peak of the pandemic.
What did the pandemic tell both of you? And I'd like to hear both of you weigh in on this. What did it tell you about the state of public health in the U.S. and where we need to make changes?
Well, the thing with public health is that you don't see it if they're doing their job. And so for a long time, people probably didn't think about public health. Maybe even for a generation, we haven't thought about it. And this is a pandemic that, unlike that's ever been seen, really. And we compare it. The closest comparison is 1918 flu, although that was a world of difference. But clearly, public health varies around the world. And the United States, as much as our health system is quite sophisticated in some ways, some of these very basic things that we talk about now, like contact tracing and just surveillance, basic things of just knowing what's even happening in the community. The mechanisms aren't there because that doesn't fall under the traditional caring for sick people. In some ways, our system is designed to take care quite well of people who have disease, but we're not always there to prevent. And you think about the CDC or the state health department, the funding cuts over the years, and really what the focus has been lately, a lot of it's been on opioids, which is important, but in a way, it's the resources have been so stretched right now. And as we think about re-engaging, one of the big conversations is, how do you further stretch the resources and how do you augment them? And you might have heard, a lot of volunteers are doing contact tracing, for example. So the state of public health is one that it's going to need to change for us to move forward.
Yeah. Rhett, I think it's also highlighted the need for better integration between our public health system and our healthcare system. For many years, they've each operated largely in isolation from the other. And, in a pandemic, you need them well coordinated. You need free flow of information. I think we've uncovered some of the problems in our tracking systems and obviously our testing systems, how long it's taken to ramp up the viral testing that we need to do the contact tracing that Dr. Malani was referencing. Because one of the ways you contain an epidemic like this is identifying people who are infected quickly and then identifying the people, household members or people they work with or social contacts who they may have put at risk, not intentionally, but by being together in recent days. And if you can sort of isolate those rings of contacts, you can really slow the spread of the infection. And we had very little ability to do that during the early months of this pandemic in the United States. And likewise, we saw the lack of integration within our healthcare system. We largely still have a fee-for-service healthcare system where each hospital is on its own. And we saw the challenges of that when you have an immediate threat like New York City did, or the city of Detroit, with a sudden surge of people needing medical care and hospital care, and very limited ability to coordinate those services across hospitals. And I think hospital leaders worked together fairly well to quickly try to address that deficit in regional coordination. But it took some time, and we probably did not handle the pandemic as well as we could have as a healthcare system because of that.
I was amazed. I live in Brazil, and so we went to Carnival, and I came back and I had COVID-like symptoms. We were able to get tested. And a day after my test, before I even got my results, there was a public health nurse that called my house and asked a bunch of questions about where I had been, where I'd gone to Carnival, who I'd come in contact with, who I was there with. I mean, I was amazed at. I mean, not 24 hours after I got the nose swab. Thankfully, it was negative, but they had contacted us and started to try to trace where we had been. And I thought that was remarkable here in Brazil.
I think it's a good story, Rhett, and we're glad you're fine. But what you're raising, the issue is that we are, at least on a national level, posed toward do we revive the economy or do we take care of public health? When it's not an either or, it's an and. So how does the medical community advance its point of view? Dr. Malani, do you want to weigh in on that? So,
yeah.
Easy question.
Yeah, thanks for another easy question, John. It's tough because there's so much coming at you with COVID. It's like a 24/7 news cycle, really since February and certainly since March, and it's hard. I think people are like fatigued to some extent, and everyone's an expert. That's the other thing. It's sort of hard to know who really is an expert and who's not, and we've heard all those stories, but this is something that there is science to guide us. And I think getting that message out and I think for individuals who are confused, I mean, rightfully confused because they hear one thing and then they hear another and, they hear like, hey, go out and pretend like nothing's happened. And then they hear, don't leave your house. It is difficult to navigate that. But, I would say for people in medicine and public health and science, to have a coordinated message. And, one of the messages that I've really tried to make clear is that there's no such thing as no risk. And I do believe we can safely restart some aspects of the economy and get back to work. And you mentioned offices and, manufacturing, which is lifeblood of our state of Michigan. How do we do this safely? Because it isn't an either or situation. If you've got people dying, in large numbers and the health system is not functioning properly, there's no economy. So hopefully it's staying on message, acknowledging that it's hard. This is hard. What we're asking for is difficult for people, but it's not going to be forever. We are going to get into that next phase. I'm confident that we will get there. It won't be soon enough, but we'll get there. But it's a good point. I think there's a need for ongoing messaging.
Are you guys excited about, we hear a lot about healthcare delivery kind of going forward, and that this is maybe push the idea of things like telemedicine even further along than maybe we would have been 3 months ago. Are you guys excited, or are some of these sort of innovations that are happening in medicine, are you excited about those, or apprehensive? What's your feeling on some of these new advances and things like telemedicine? I think that's
sure. Rhett, I'm bullish on telemedicine, or we sometimes call it telehealth or virtual visits. Mm-hmm. When I look back at our own health systems experience here at the University of Michigan, I feel that we made more progress in advancing telehealth and the virtual care that we provide by video and telephone in the first month of the pandemic than we might have in 3 or 4 years without the pandemic. Mm-hmm. The healthcare system in normal times changes slowly, but we were forced to use technology and new approaches to communicating with patients. And as physicians and nurses and other providers, we all learned quickly. I had not done any video visits with any of our patients before April 1st. And, now I feel comfortable with that technology. And obviously there are things that we still need in-person care for, and we can't do everything through telehealth. But we're estimating that potentially as we get through the pandemic, a quarter of our interactions with patients going forward, even in the post-pandemic phase, may now be through virtual cares, through video and telephone visits. And at least for now, the Medicare and Medicaid programs and private insurers are paying for those visits at the same rates, the same fees that they would provide for in-person visits. For now, that's part of the public health crisis and making sure that people's needs are met. But I expect that some form of payment for that virtual care will continue beyond even the end of the pandemic, and some of that will be to patients' benefit, because there are many things we can provide for patients that don't require them to travel to a doctor's office or a hospital, and we can give them good medical advice and help them to use their time more wisely.
Great. Now, Dr. Malani, Preethi, you have a distinguished career in academic medicine and you're well published, but of late, you are maybe better known in the world through your commentary in the New York Times, ESPN, and other sports venues, because you have been playing an advisory role. So what's the smart thing for colleges to do when they bring their athletes back to campus?
Yeah, so John, sports are not just college sports, but really high school sports and club sports. Now, this is part of our life, and there's a lot of benefit to the student athletes, and I stress the student part, because our student athletes are students first, and they're athletes second. And the discussions that I've been involved with have been both at the University of Michigan, supporting the overall planning and working closely with our athletic director, Ward Manuel, but also working across the Big Ten and with the Big Ten commissioner. And, with the planning, just this week at the University of Michigan, our first batch of athletes have returned to campus. And I really make a distinction between return to training and return to competition. And a couple months ago, neither of those really seemed very likely to me. But you know what? Return to training, we've sort of thought about it and come up with a system to try to make it as safe as possible. And again, just like the classroom doesn't look the same, training doesn't look the same either. And small groups, having some testing, different protocols on how to manage people with symptoms, individuals, keeping the coaches safe. We talked about professors. It's the same thing in a athletic setting with coaches who may be older and medically vulnerable. But so right now we're focused on getting people back to training. And then as the decisions get made regarding the academics calendar and what the classroom may or may not look like, we can have a discussion around return to competition. But I think that's a lot more complicated because it involves travel. It involves lots of spectators potentially. I'm curious to know what's happening around the world. I saw baseball in South Korea. I know there's discussion of soccer or football coming back in Europe, and some discussion around MLB and NBA here. But I think we're a ways away from knowing what it might look like. And I just want to point out that I do think it's an important thing. It's a sense of normalcy. But if something like gathering a large number of people to watch a basketball game or a soccer game or a football game puts the whole community at risk, then I think we have to really think about that and weigh what's essential and what's not.
Yeah, that makes sense to me. I'm sorry to follow up on this, John, but I want to ask you more about telemedicine or telehealth. What does an interaction with a patient via telemedicine look like, or what do you you feel like you can give the same level of care?
Well, it's certainly not.
I've never done it, so I'm just curious what that interaction looks like. Yeah.
So, we now have software that was activated in our electronic health record, in recent months that enables us in a secure form to communicate with patients over video. Now, not all patients are willing or able to use the video technology, and in that case, we can still fall back on a telephone call. But you cannot see the patient's expressions or do some basic components of, say, a skin exam that you could do over video. I think where we can really excel with the virtual care is in what we call the history taking, sort of talking to patients about their symptoms and their concerns, and in the counseling and some of the shared decision making that we do, the discussion of what someone's treatment options are or what tests they might need for their condition. One of the areas that's actually, I think, embraced the virtual care is mental health and psychiatric care. Much of that care is, even pre-pandemic was done through conversation. There, sometimes there's a basic physical exam, but much of it is through the discussion between patient and doctor. And so it's those components of medical encounters that I think we can provide most effectively. I think it also, my personal sense is that this sort of virtual care works better when the doctor and patient know each other from previous contact in person. I think it's somewhat more challenging. It certainly can be, the first point of contact. And I know a number of health systems around the country are providing virtual care through their hotlines when patients had symptoms that they were concerned could be coronavirus and causing COVID-19. They could call in and speak to a doctor or nurse, sometimes over video, and be counseled on whether they needed to be tested, whether they needed to come in for an in-person evaluation. Obviously, if they look seriously ill, they might need to come to an emergency department. So those are the types of sort of virtual care where I think it can work fairly well. But we're all learning that, doctors and patients and nurses and others providing the virtual care, we're still learning together how best to do this. I have some colleagues in surgical specialties who find it's a very effective way to do routine post-op visits. So if a patient's had elective surgery, and normally they might drive an hour or two to come in and see their surgeon to take a look at their wound and ask if they've had a fever and ask if their pain is under good control or gone away. For patients who aren't having complications, we're discovering a lot of that can be done through a video visit and, saving them, what might be an hour or two long drive, depending on where they live. And, then sitting in a doctor's waiting room, to have a 5 or 10 minute visit with the doctor.
Yeah, it seems very efficient to me. Yeah, I mean, that makes sense.
I liked what you said, John, about the learning aspect of we're all learning in this together. And flipping it to you, Preeti, as you look organizationally wide at the university, what are the learnings that you spoke very eloquently about the university being about connections and relationships and people coming together. So how do we emulate that in a virtual culture?
Yeah, it's interesting. One of the things, like even this discussion we're having here, I feel like I'm close to you guys. I think we have adapted in ways that we never thought we could. Some of the teams that I work with on a daily basis, our lead group, we meet for about 1 to 2 hours every day, and I feel an incredible closeness to them. So I think with time and familiarity and also the intensity of the work and the intensity of the time, when we talk about students, and there are a lot of students who are actually on campus, even though we're not technically in residence right now. And if I talk to my own son, the folks that they are around, they've out of necessity, they've actually developed deeper relationships. And this generation, the issue of loneliness on college campuses has been something that's gotten a lot of attention. And I'm very curious to know how it's going to be where, in a sense, like you're going to be in smaller groups, like your hall might be your family, your house that you live in might be your family. And will that give people an opportunity to actually develop more meaningful, deeper relationships, in a world where, we might be surrounded by people, but feel very disconnected. So even in this virtual world, I feel that we're learning new things. I would just add to John's comments about telehealth. One of the benefits for me has been seeing patients who I've known for a long time in their home setting. And, you see who's around them and you see what they're doing, what it looks like. And I think that also has some benefits. It's not my preference. I would prefer to see them in person because that's what I'm comfortable with and what I'm used to. But, humans are very adaptable if they're forced to be. And so we've all adapted in ways that are very interesting. And, people have workplace gatherings, like they all get together on Zoom and check in socially. So I think there are going to be innovative ways that we maintain connections in a world where we're disconnected.
And John, for example, we could tell that you're an avid piano player and reader.
Yeah, and in a cluttered office too. I think that's an important thing about relationships, as we are learning more about one another. And I think, Preeti, you raised a good point about some of the connections being less frequent but deeper. And really, isn't that the ultimate thing, as opposed to gets us away from the quote social media? I have 1,000 friends, none of whom I've ever met face to face, but and maybe for the college students or the rest of us are learning from who our real friends are, and we stay connected with them in a way if it's virtual, and then we'll pick that up on the other side in a different kind of way. So I think we're all learning, I guess, the sub-theme of our conversation today. So.
Well, and John and Rhett, I think, another aspect of reopening the campus is thinking about which classes are best conducted in person and which ones can be provided quite well online. So, in some of our, large lecture halls where there might be 300, 400, 500 students in a room together, there's not necessarily much interaction with the professor, and that learning can be done quite well online if the lectures are well organized. Whereas in a seminar or a dance studio or a music class, that personal connection is still very important. And I think that's what we're trying to strike a balance on, in reopening the campus, preserving some of the smaller gatherings where the interaction is very important, and moving some of the large gatherings that maybe could have been done online 5 or 10 years ago, but we just kept them in their existing format as a large lecture out of habit. Some of that is changing, and it allows us to flip the classroom, so to speak, where students potentially do more preparation online and then are better prepared for the interactive parts of their education.
Is there any? We had a show last week, and it was fascinating because it seems like there's an increase in anxiety and stress, and across the board, mental health is. Issues are sort of increasing with people. Is that something that the university and other universities are in conversation with your colleagues around the country? Is there going to be more attention paid to that now, you think, in the workplace and at the university level?
Yeah, so Rhett, I think it is something that people have been paying attention to, and I'm most familiar with what we've been doing at the University of Michigan, and it really encompasses all individuals, the students, faculty, staff, and actually trying to equip staff in particular with good resources and some training. I had a vision last summer with the idea of, we ended up training about 120 people in a program called Mental Health First Aid, hoping that people would have those conversations with the person next door in their office saying, I'm concerned about you. You don't seem like yourself. What's going on? That idea of reaching out, and people's lives are complicated, and they were complicated before COVID. And I think in a lot of ways, they're much more complicated. You think about people's caregiving, whether it's children or older adults or another adult, and just the complications of having someone in your home when there's a pandemic. The idea of, quote, working from home when you're also trying to manage caregiving. So I think there is a lot of stress out there. I'm really pleased that our state has also engaged on this. Our governor has provided resources for citizens of our state. And I think those things do help. At the same time, this process builds some resilience too. And I'm not saying that these are not real issues. They're very real issues. But I think having a little bit of grit and resilience is also helpful in some of these spaces, particularly with our college population, because as you note, depression, anxiety, loneliness, these are all epidemic. And I'm hopeful that after losing like the last half of your senior year and senior skip day and prom and graduation, that people are going to be ready to engage meaningfully.
Are there some resources, places where people can go? I'm thinking about it from a work context. If I'm a business owner and I know that I've got 30 people who are stressed out about coming back to work, and are there some places I can turn for good information on how to deal with that and how to ask the right questions? Because that's what I would be concerned about is, what questions can I ask, and what, how much can I try to help, I guess.
Yeah, a lot of businesses I know have an employee assistance program is the term that they used a lot, EAP, and we've renamed ours to actually use the word counseling because that's what it is. And again, I think different places have different resources, but people are often not familiar with the resources. What I have found, that was one of the things here, to just make people aware and actually to really address that issue, because as people do come back, it's natural, that re-engagement process is going to be challenging for some people. And there are likely some national resources too, and some shared resources. I know that there's some that our state is using. Headspace is one, and there are others like it. But for smaller businesses, probably contracting it out and offering that, because I think even the fact that you're offering it is an important statement of empathy and compassion for your coworkers and employees.
And I think that's a very valid point, and I'll throw it to John. One of the things we learned about PTSD from our soldiers was, at first it was regarded as stigma, but senior officers came forward and talked about their own problems as a means of making it safe for the quote lower ranks to seek it. And I think I know Rhett and I, when we talk to executives, we do the same thing. So do you have a thought on that, John? You're a leader and a clinician at the same time, your perspective. So.
Yeah, I think removing the stigma from seeking mental health support or counseling services is very important, and I think leaders have an important role to play. Communicating, being visible, and the time. In essence, we're living through the twin crises of the COVID-19 pandemic, and now the racial injustices in our society. And both of those are creating lots of added stress for many people in society. So, I think another practical suggestion would be for employers and leaders of organizations to understand what mental health benefits are offered through, if the employer is offering health insurance, which most do, what are the mental health benefits that go with that, and underscoring and making, people tend to pay attention to their health benefits during the annual enrollment period, and most companies do that in the fall. But it's really a year-round need, and you want people to be aware that within those employer-sponsored health insurance plans, that there is a mental health benefit. We have now mental health parity in the sense from federal law that requires that mental health services be included in health insurance plans, and they can be incredibly valuable for helping people get through acute or chronic needs that they have related to their mental health or the needs of the family and others that they rely on.
Thank you. We are out of time, unfortunately. Thank you guys so much for providing your sort of expert thoughts on these questions. I think these are questions that a lot of people are asking, and it's always good to have people who know what they're talking about and can give us reliable information that we can trust. Thank you so much for being with us.
Thank you.
Our pleasure. Thanks.
And thank you, Dr. Malani and Dr. Ayanian, for being our guest on What's Next. Stay tuned for future episodes coming up as we explore what our new normal will be like and the people who will shape it. Thank you both, Preeti and John.
Thank you.
Thanks.